So I'd like to begin by welcoming you all to today's Dossiter Health Ethics Seminar. Just as housekeeping to begin, I'd just like to remind people that we'll be keeping all of the microphones muted for the beginning of the presentation, but during the presentation, we will be unmuting the microphones. Okay? Following the presentation, we'll unmute the microphones to allow time for discussion and questions. Today, it's my pleasure to introduce Heidi Jantz, who's an adjunct member of the Dossiter Health Ethics Center. She'll be speaking on the topic, Duty to Accommodate. And Heidi, it looks like your slides are just flipping in and out of presenter view and full screen. Okay.
I'm working on it.
For sure. We are experiencing some technical issues today, so I appreciate everyone's patience. There is a couple gray squares on the top of her PowerPoint. We are aware. We're trying to fix that, but likely that will just be something that we'll all be living with for the presentation. Okay. At that point, I will turn it over to you, Heidi, and I'm looking forward to hearing your talk.
Thank you very much. Thank you very much, Michael.
Systemic ableism that relegates people with The COVID-19 pandemic has laid bare the systemic ableism that relegates people with disabilities to the margins of both society and healthcare. Running contrary to the oft-repeated public health mantra of "we're all in this together" have been stories of COVID-19 outbreaks in long-term care facilities and group homes causing personal support workers and healthcare aides to fall ill themselves, and prompting those who remain to abandon their elderly and disabled clients. Interestingly, and tellingly, while the deplorable conditions of seniors languishing in long-term care facilities has, rightfully, garnered national attention in recent months, the abandonment of physically and developmentally disabled adults by staff at Participation House, a care home in Markham, Ontario, in April, was little more than a blip in the 24-hour news cycle. For both the mainstream media and the general public, there appears to be a clear qualitative distinction between the physically and developmentally disabled residents of Participation House and the, mostly, senior residents living in long-term care facilities. Equally disturbing, and equally ignored by the vast majority of mainstream media, has been the development of critical care triage protocols which list the pre-existence of a disabling condition as an exclusion criterion for critical care, in the event that rationing of critical care resources becomes necessary due to a massive influx of critically ill patients with COVID-19. All of these things point to the fact that Canada suffers from a pre-existing condition that is making COVID-19 much more lethal for entire segments of its population. The name of this condition is ableism. What I'd like to do here in the next 40 minutes or so is to examine some ways in which the prevalence of ableism in Canadian society in general, and within Canada's healthcare system in particular, function as pre-existing conditions which are putting people with disabilities at substantially increased risk during the COVID-19 pandemic. I will begin with an overview of the concept of ableism, and the ways in which it functions to keep people with disabilities on the margins of Canadian society. I will then go on to consider some of the ways in which common healthcare policy and protocol responses to COVID-19 can be seen to have ableist underpinnings, and often thus result in the exclusion and abandonment of people with disabilities. I'll conclude this presentation with a consideration of the ethical imperative for a human rights-based approach to healthcare policies and protocols related to COVID-19. So, let's begin, then, by looking at the concept of ableism, and the ways in which medical and societal ableism in Canada function as pre-existing conditions in the context of COVID-19. Ableism can be defined as discrimination and social prejudice against people with disabilities based on the belief that typical abilities are superior. At its heart, ableism is rooted in the assumption that disabled people require fixing and defines people by their disability. Like racism and sexism, ableism classifies entire groups of people as less than, and perpetuates harmful stereotypes, misconceptions, and generalizations about people with disabilities. Clear, yet unacknowledged, evidence of ableism can be seen in everything from the way in which buildings are built to exclude people who do not walk or see, to the way in which students with disabilities are taught that it's better to look, move, and behave as much like their non-disabled peers as possible, to the way in which terms associated with disability are used as insults in common parlance. Unlike racism or sexism, however, ableism remains, in the words of Canadian disability scholar Gregor Wolbring, one of the most societally entrenched and accepted isms. Healthcare has traditionally been viewed as a benevolent discipline in which every human life is valued equally, without any form of prejudice or discrimination. While this may remain the ideal to which healthcare aspires, the reality is that, as individuals, healthcare professionals are not immune to the influence of dominant societal understandings of, and attitudes towards, individuals and groups of people deemed to be others. Ghali and colleagues observe that despite their intentions, personal goals, and normative expectations, even health professionals are unconscious bearers of implicit social biases that affect the quality of professional interventions. They further contend that, immediately, and from early life and thereafter, people perceive individuals with disability as vulnerable and of low competence and, accordingly, treat members of this group differently. Despite the major role that medical professionals play in the lives of people with disabilities, research indicates that people with disabilities frequently encounter discrimination in healthcare settings, even in ordinary times. Studies have consistently shown that, as a group, healthcare professionals tend to substantially underestimate the quality of life of people with disabilities. Such erroneous judgments about the quality of life experienced by people with disabilities can result in treatment options for people with disabilities being either limited, or altogether eliminated. At the heart of such decisions is what disability scholar Joel Reynolds has termed the ableist conflation of disability, suffering, and death. Wherever operative, the ableist conflation flattens communication about disability to communication about pain, suffering, hardship, disadvantage, morbidity, and mortality. What makes medical ableism so dangerous and so insidious at the same time is that it often presents as common sense. James Cherney argues that ableism is that most insidious form of rhetoric that has become reified and so widely accepted as common sense that it denies its own rhetoricity. It, goes without saying. Within this milieu of common-sense ableism, people with disabilities are routinely made vulnerable in medical settings. For example, studies have consistently shown that the emergency department environment can be stressful, and even dangerous, for people with developmental disabilities and/or communication disabilities, both because deficits associated with these conditions hamper these individuals' ability to communicate their concerns, and because staff often do not have the skills needed to work with them. The advent of COVID-19 has only exacerbated these stresses and hazards, sometimes with lethal consequences. The tragic death of Arius Knight in April 2020 powerfully demonstrates the real and present danger that medical ableism poses for people with disabilities in the wake of COVID-19. Knight was a 40-year-old BC woman who had cerebral palsy. She was nonverbal, but could communicate with her family and aides through facial expressions, which they had learned to recognize and interpret. She died of a respiratory illness on April 18, a few days after she was transferred to the hospital from the group home in South Surrey where she had lived for a decade. Because of COVID-19 visitor restrictions, none of Knight's caregivers or family members were allowed to be with her in the hospital, and she died alone. Even prior to COVID-19, many people with disabilities, especially those with communication disabilities, have been fearful of going into emergency because their support people may not be allowed to stay with them. Arius Knight's death, and the circumstances surrounding it, sparked an outcry from disability rights advocates across the country. The newly appointed Federal COVID-19 and Disability Advisory Group, CDAG, presented an urgent recommendation to the Federal Minister of Health that she strongly encourage her provincial and territorial counterparts to revise their hospital visitation policies so as to designate family members and support workers who provide care and assistance to a patient with disabilities as essential visitors. While the Federal Minister of Health did agree to take this recommendation forward to her federal and provincial counterparts, to date, I have only been able to confirm that visitor policies have been amended to adopt this recommendation in British Columbia, Alberta, Saskatchewan, and Ontario. Although this may be an incomplete list, it nevertheless speaks to the fact that recognition of the right of people with disabilities to have access to their personal support people in medical settings during this COVID-19 pandemic remains far from being universally guaranteed across Canada. Another aspect of the healthcare response to COVID-19 which has been particularly prone to the influence of ableism is the development of critical care triage protocols, which would be implemented in the event that the demand for critical care resources, such as ventilators, exceeds the supply, making the rationing of these resources necessary. As these critical care triage protocols started to be rolled out last spring, it quickly became evident that the vast majority of them listed pre-existing disability as an exclusion criterion for critical care. I feel that it's important to note here that the clinicians and ethicists who crafted these protocols no doubt considered the decision to list pre-existing disability as an exclusion criterion to be well supported by statistical evidence. Nevertheless, the resulting outcry and denunciation of these protocols from disability rights advocates was both swift and unanimous. For example, in response to the public revelation/leak of Ontario's critical care triage protocol in April, the Arch Disability Law Centre issued an open letter to the Ontario provincial government. This open letter, which was signed by 204 organizations and 4,828 individuals, makes the following recommendations. 1. Persons with disabilities cannot be deprioritized for critical care on the basis of their disability. According to the triage protocol, some people will not get critical care because of their disability. For example, the triage protocol identifies particular disabilities, such as cognitive disabilities and advanced neurodegenerative diseases including Parkinson's disease, and amyotrophic lateral sclerosis. Persons with these disabilities may in some stages of their disability be deprioritized in determinations about who receives critical care. It is imperative that decisions about who receives critical care should be made using objective clinical criteria directly associated with mortality risks of COVID-19, and must not be based on stereotypes or assumptions about a person's disability, and longer-term mortality rates that are not directly related to COVID-19. It should also be made clear that by virtue of someone's disability, they will not be deemed a lower priority and passed over for another patient who does not have a disability. 2. The triage protocol must clearly state that clinical judgment must not be informed by bias, stereotypes, or ableism. The triage protocol explicitly states that clinical assessments cannot take into consideration a patient's socioeconomic privilege or political rank. As the healthcare system has a long entrenched history of ableism, the triage protocol must also explicitly state that implicit disability-based bias, stereotypes and ableist assumptions cannot factor into clinical judgment or assessment when allocating critical care resources. It must also make clear that decisions cannot be made on the basis of human rights protected characteristics and intersecting identities. We understand that clinical judgment is an important part of the triage protocol, but there must be necessary safeguards to ensure that particular marginalized groups are not adversely impacted. 3. Persons with disabilities cannot be deprioritized for critical care based on the supports they receive for daily living. According to the triage protocol, persons with disabilities who receive accommodations or supports from others for daily living are in some circumstances less likely to receive critical care. This means that the triage protocol has the effect of deeming the lives of persons who require assistance as being less worthy, or assumes that they have a lesser quality of life. These kinds of criteria are discriminatory and devalue the lives of persons with disabilities. The protocol invites value-based judgments on the basis of disability-related accommodations, which are a basic human right. 4. The triage protocol must clearly ensure that persons with disabilities receive necessary disability-related accommodations. The triage protocol does not have a clear statement that persons will receive necessary disability-related accommodations in the implementation of the triage protocol. Accommodations, such as interpretation, support, or other services to access medical services, are a basic tenet of human rights law. Disability-related accommodations ensure that persons with disabilities have equal opportunity to receive, understand, and benefit from critical care. It appears that this open letter had at least some impact on the further development of critical care triage policies in Ontario. In its subsequent submission to the Government of Ontario dated July 20, 2020, the Arch Disability Law Centre notes that Triage Protocol 2 demonstrates some improvement over the first version, namely the removal of pre-existing disability from the list of explicit exclusion criteria. Nevertheless, the submission goes on to list the following recommendations to ensure that Triage Protocol 2 does not have an adverse impact on persons with disabilities. 1. Non-discrimination must be a guiding principle in its own right to ensure appropriate weight is given to human rights in triage decisions. 2. The triage protocol must not rely on medical utility as its primary guiding principle, as it leads to adverse consequences for persons with disabilities, and fails to consider systemic health discrepancies. 3. The framework must shift from a focus on the intention not to discriminate to whether adverse impact, discrimination, flows from the approaches embodied in Triage Protocol 2. 4. Ontario Health must communicate to every hospital and medical association/organization that the Triage Protocol dated March 28, 2020 is not to be relied upon or implemented. 5. Clear language and plain language versions of all drafts and the final version of the Triage Protocol are to be produced and distributed widely so that all relevant stakeholders are able to understand the information and provide feedback. 6. Wider consultations are to be undertaken by the bioethics tables to ensure that the perspectives of persons with lived experience from marginalized and disproportionately impacted communities are heard and inform the drafting of the triage protocol. 7. The triage protocol must not rely on the clinical frailty scale in any capacity. 8. The triage protocol must eliminate eligibility criteria that considers survivability beyond the acute COVID-related event. 9. The triage protocol must provide clear and specific guidance and direction as to how random selection should be carried out. 10. The triage protocol must include an individual dispute resolution process to ensure fairness, accountability, and due process. 11. The triage protocol must include a section dedicated to providing guidance and direction on the duty to accommodate. At this point, some of you may be wondering why I've spent so much time talking about developments that have taken place in BC and Ontario, but not looking at, for example, Alberta's critical care triage protocol. The simple, yet very troubling, answer is that it is virtually impossible for someone without an Alberta Health Services digital ID to access this document. I would argue that such a lack of transparency is highly problematic in that it effectively stifles public dialogue around this issue, while seriously undermining the trust of vulnerable populations, such as people with disabilities, in the healthcare system. What little information about Alberta's critical care triage protocol that is accessible to people outside AHS appears in a paper published in the April 2020 issue of CMAJ. In this paper, Parhar and colleagues describe the development of Alberta's critical care triage protocols in the following terms. In Alberta, a subgroup of the Provincial Critical Care Strategic Clinical Network's COVID-19 Pandemic Planning Group has proposed extracorporeal life support ECLS referral based on a principled approach. Early assessment of each case by an ECLS consultant, who may have additional management suggestions before consideration for transfer to an ECLS center or cannulation, can assist optimization of conventional medical therapy. We believe that having an ECLS consultant on call 24 hours per day, 7 days per week, should be standard of care. Patients with advanced age, high burden of medical comorbidities and poor likelihood of recovering sufficient lung function to promote independent recovery may be deemed unsuitable ECLS candidates. This is because it is unlikely that ECLS will offer additive therapeutic benefit beyond conventional management. Patients who have received mechanical ventilation for more than 7 days are unlikely to recover native lung function, even with rescue ECLS. Parhar and colleagues go on to explain that pandemic ethics usually apply utilitarian principles, with application, redirection, or restriction of resources to those who can benefit most. Patients with the best perceived prognosis tend to be prioritized, necessitating more restrictive entry criteria and adaptation of usual exit criteria. Waning capacity of ECLS through attrition of staff or supplies or overutilization related to high demand should also be considered. The province of Alberta has developed a 4-level system of triaging and safe operation of ECLS services, with Level 1 indicating a state of sustainable operations, Level 2 a state of increased strain on resources that will restrict an expanded group of patients from accessing ECLS, Level 3 a high strain on resources requiring that ECLS be restricted to only those patients with the highest probability of survival, and Level 4 an overwhelming demand for critical care resources, in which ECLS services would be suspended to redirect all available critical care resources to other critically ill patients. Decision-making to move through each of the 4 triaging stages is centralized to an emergency command center that incorporates up-to-date information from all ECLS and critical care programs related to service demand and healthcare capacity. Cursory though it may be, this summative overview of Alberta's critical care triage protocol makes it readily apparent that the very same human and disability rights critique and corrective recommendations that the Arch Disability Law Centre issued in response to Ontario's critical care triage protocol are applicable to Alberta's as well. This is because, like the first version of Ontario's protocol, Alberta's protocol lists the presence of a pre-existing disability as an exclusion criterion for critical care. Furthermore, Parhar and colleagues explicitly situate the development of Alberta's protocol within an established convention of basing pandemic ethics on utilitarian principles which dictate the application, redirection, or restriction of resources to those who can benefit most. Within pandemic ethics, patients with the best perceived prognosis tend to be prioritized, necessitating more restrictive entry criteria and adaptation of usual exit criteria. Such privileging of patients based on which ones have the best perceived prognosis is clearly rooted in ableist notions of disability as always, automatically being detrimental to a person's quality of life, and consequently results in people with disabilities being summarily denied critical care. I want to stress that Parhar and colleagues make it clear that the protocol about which they write is only a proposed protocol. Even so, the utilitarian ethics which this draft Alberta Protocol espouses is very much in line with the utilitarian principles that were seen to be the cornerstone of most of the critical care triage protocols that we've seen countries around the world adopting. Hence, it seems to me that it's entirely reasonable to operate from the premise that the Alberta Protocol has its origins in the very same kind of utilitarian ableism that is evident in the Ontario Protocol. We are thus left with the question, what viable alternative is there to the utilitarian and ableist pandemic policies and protocols which have been implemented across Canada and around the world during this COVID-19 pandemic? It seems to me that the clear evidence of the pervasiveness of ableism throughout Canadian society in general, and within Canada's healthcare system in particular, that has been made manifest during this pandemic can be ameliorated only by a wholesale shift from an ethical framework that is based on utilitarianism, to an ethical framework that is based on human rights in general, and disability rights in particular. The link between ethics and human rights is at once intrinsic and contested. Anthropologist Mark Goodale conceptualizes human rights as a particular ethical theory constituted through social practice. Ethics researcher and clinician, the Dossiter Center's own Dr. Wendy Austin, takes a more nuanced approach to analyzing the relationship between bioethics and human rights. The central assumption of the rights paradigm is that every person can make certain claims based solely on their humanness. Taken literally, a right to health makes little sense. No government can guarantee the health of a citizen. The right to health, however, is actually shorthand in rights discourse for the more complex terminology of international treatises and documents. Health within the rights paradigm is an entitlement, a very different concept from health as a commodity. As a right, individuals can lay claim to it, which, symbolically at least, has great significance. Governments ratifying UN agreements with articles pertaining to health are obliged to report on actions taken to improve the health of their people. Within the context that Austin delineates here, disability rights is a subset of human rights. Jerry Allen Winter notes that the disability rights movement, while by no means a monolith, is one whose slogan is "Nothing about us without us." The disability rights movement seeks to replace oppression with empowerment, and marginalization with full inclusion. Having its roots in the disability rights movement, disability ethics, likewise, is centered around the tenet that the perspectives and lived experiences of people with disabilities should always be central to discussions and debates about ethical issues involving disability and people with disabilities. A human and disability rights-based ethical framework thus takes as its core principle the equal worth and worthiness of all human life, regardless of the presence or absence of disability. Eva Kittay has suggested that a contributing factor to the devaluing and disparagement of disability is a failure to practice what she calls epistemic modesty, that is, knowing what one does not know. Within a human and disability rights-based ethical framework, therefore, epistemic modesty becomes a primary duty of clinicians who are treating disabled patients, for it is only through practicing epistemic modesty that clinicians can ensure that their treatment decisions are not influenced by latent ableism in their assumptions about the quality of life experienced by people with disabilities. Periodically in the course of the 8 months since the pandemic started, I've listened to, and/or participated in, conversations on this topic with and among colleagues in medicine, clinical ethics, and disability studies. Almost invariably, these conversations culminate in the, often exasperated, question, so, who gets the ventilator? Rather than attempting to propose or impose a one-size-fits-all answer, yes, okay, I may be weaseling just a bit. I'm going to leave you with what I see as the 7 most crucial guidelines for ensuring that pandemic medical policies and protocols align with human rights and disability ethics principles. 1. Non-discrimination and equity must become the cardinal ethical principles on which all healthcare policies and practices are based. 2. Healthcare policies which directly impact marginalized populations must be clear, in terms of being easy to understand, and transparent, in terms of being readily available to the public. 3. Critical care triage protocols must not rely on medical utility as a central guiding principle. The adoption of medical utility as a central guiding principle for critical care triage protocols leads to adverse consequences for persons with disabilities, and fails to consider systemic health discrepancies. 4. Critical care triage protocols must not rely on the clinical frailty scale in any capacity. 5. Policy and protocol frameworks must shift away from a focus on the intention not to discriminate to whether adverse impact, discrimination, flows from the policy and/or protocol. 6. Critical care triage protocols must eliminate eligibility criteria that considers survivability beyond the acute COVID-related event. 7. Critical care triage protocols must include a section dedicated to providing guidance and direction on the duty to accommodate a patient's disability-related needs. I firmly believe that a wide-scale adoption of these guidelines would make a very scary and uncertain time a little less scary and uncertain for people with disabilities. Thanks for your attention.